Great, so we're gonna go ahead and get started. First topic on the agenda is to approve minutes from December 14th was the last time we met. And I feel like it was warmer in December than it was right now, but anybody have any changes or patients?
I move approval.
Second.
All right, perfect. All those in favor?
Aye.
Aye.
All right, any opposed? All right. Okay, that was quick. All right, before we move on to the family planning site, I know yesterday was a big day with Giving Hearts Day, and it sounds like Gladys Ray had $26,000 in donations. I think their goal was 8,000, so that's.
I think it might have been 10, but
8
this
or
was their
10?
first year as being on that list, and so the money will go directly towards client services, so it's awesome.
Yeah, it was great. They've been posting lots of videos to social media, just kind of trying to advocate for themselves, and it was great. So congrats to that program and all the visibility that they've gotten. So pass that along.
We'll do that.
All right, so the next announcement was on the family planning site visit.
Larry.
Good afternoon. Thanks for the opportunity to share a little bit of information about our family planning site visit. As a federally funded Title X clinic, we are required to go through a site visit from the North Dakota Department of Health Division of Family Services every 3 years. And this year, January 22nd and 23rd, we had our site visit. And just briefly, the site visit covered such things as financial, administration, clinical services, as well as education and outreach. And many of our public staff, including Desi Fleming, Melissa Perella, Vanessa Gunning, and other staff were involved with the site review. And there were no major findings identified by the team from the North Dakota Department of Health, but there were minor recommendations. Comments that were shared during our post meeting at the end of the site review were such things as the policies were in place, all up to date. They were impressed with our recent cost analysis that was completed in 2017. Another one's going to be completed in 2019. They commented on the friendly and welcoming environment, as well as our staff. They felt a strength of our clinic was the referral process and the number of community partners we refer clients to. Community education and outreach they felt was well done, and they were impressed by the various venues we market our program, our Title X program, from Facebook to billboards to just print ads. They were impressed, knowing that one marketing area might not hit one group of individuals, but if we use a variety of different means, hopefully we can share the mission and the services available to our clients. Comments about how beautiful and clean the building was, they said that a few times, and then the excellent holistic care provided to the clients and the referral process that was documented in the client's charts. And with that, our clinic continues to appreciate the support from the Board of Health. I know when we submit our grant application, the board has approved our grant and provided suggestions that I am able to incorporate in our grant. So thank you for your continued support.
Thank you for providing such wonderful services.
What were the couple criticisms?
There were such things as they would like us to be a little bit more detailed in our standing orders. So we're going to look at that, work with our providers, our medical family planning director, Dr. Stefan Christensen, and be a little bit more detailed. We happen to be the largest family planning clinic in the state of North Dakota, and it's extremely rare that we do not have at least one nurse practitioner in-house for orders and to assist clients. However, being proactive, we want to make sure that we have standing orders in place in the worst case scenario, because we do not want to turn people away who need us for services. So they read through our standing orders, And they just recommended that they're a little bit more clear, especially for individuals who are new to our clinic, a new staff member, so they're a little bit more clear to understand, because things that we have done for years, and a lot of our staff have been there for many years, they know exactly what that means, but maybe somebody new doesn't. So it's nice to have some outside eyes looking at those things and giving us suggestions on that. Besides that, some clerical mistakes, some omissions that would make a good QI study, a quality improvement study, to look at how we can make sure that certain things are coded correctly, that things are not missed, but just things like that. Nothing that was consistent in nature, but things to look at and take note of. And again, as being proactive, thinking, I'm thinking we can write this up as a QI study, and to me, it seems like a good one.
But nothing substantive, nothing big. Okay,
Not at all.
Thank you.
Yep.
Other questions for Larry?
Okay, thank you.
Larry? Performance management?
That would be me. I'm going to try not to blow this speaker out. Greg told me not to be cautious with my voice. So, I handed out 2 different documents. The first one is our Community Health Improvement Plan 2-year progress report. Because of the TB presentations, I'll go through it quick and we can discuss it at the next meeting so you guys have a chance to look through the material and see what's all in there. Yep, that one there. So the 2017 information is all in the red. I know it's not the easiest document to look through, but we identified our goals, our strategies, and the reporting that we've been able to go through so far. This is probably our last report for the current Community Health Improvement Plan, because we're working on the new Community Health Assessment, which then we find out our needs, we identify, and then we build into our improvement plan. So that doesn't mean that some of these goals won't probably carry over. As we all know, childhood overweight and obesity is an ongoing issue, and substance use and abuse as well. So please take your time, look through that. If there's any questions, we can address it at one of the next meetings. And then the other document I have for you is our customer survey. As you can see, from October to December, we got 30 responses, which was 25 more than I kind of expected us to have for the first quarter, which was great. Really good feedback. You can see I put in all the comments. These are straight from SurveyMonkey, and I just tried to make a layout that was nice. And Commissioner Strand knows that I like to use colors, so I added colors for Commissioner Strand.
Thank you.
You can see very good responses overall. People are pretty happy with the services that they've been receiving and communications and ability to meet the needs if there are translation services or whatever the situations are. We have been really good about meeting those. We had at the last management meeting this past Monday, we discussed as part of performance management tweaks that we would want to do to the survey, anything that we would want to gather more information, little adjustments. So please, if you have any suggestions for that as well, we can discuss that at the next meeting as well. And as of this morning, we are, including the 30 here, we are up to 81 responses for our survey. So this next quarter is already taken off. So we'll like to capture as much information as we can. Any questions for me? I went through quick, so we have more time for the other presentations.
I'd just like to say quickly that these are really impressive numbers, so congratulations.
Thank you.
I spend a lot of time looking at these things in my work, and it's really hard to get that high of a percentage of people who would recommend your facility and that staff are friendly. And I mean, this is just, it will be great for you guys to develop, further improve things, but this is really impressive, and those are great responses from your patients, so it shows that you're doing a great job.
Thank you.
Yeah.
And thank everybody from all the divisions. They've been really great about it. So.
Perfect. Any other questions for Justin? Okay. Is there a second part to the performance management, or are we going on to budget? Okay, going into budget. All right, Melissa, I assume?
Yes, hello. The budget is actually, I see on the agenda, is listed as through January 31st, but it's actually the ending period through December, which includes period 13. Happened to be a lot of salary for the last 2 weeks of December, December 31st also. But I'm happy to report that while I was a little bit worried our expenses would be much higher than this, they came in just over 100% of our budget, and our revenue came in just under 100%. So we did pretty well for a year that was really kind of in flux, lots of changes. So I think we managed it pretty well and came out good in the end. Any questions on any of those numbers?
If I might, how are we sitting on issues like the opioid crisis? I know we had some earmarked funding just in case to start with. Are we okay going forward, or do you see more needs coming, or?
We're still lots of changes in the harm reduction area, and I think in the budgets, the divisional budgets themselves, that's where we ran over, and we will probably continue to run over there until we make some big changes hopefully this next year in the budget, because it's a lot of new staff and it's a lot of time. So
just so we're proactive in our budgeting for this next cycle.
yep.
Yeah, because there are, in the harm reduction, the grants are very specific to certain aspects that it will fund, and then it doesn't fund other pieces of it. So that's where we have to really take a look at that and make sure we have enough for everything to support the program.
Other questions for Melissa? All right. Okay, fourth quarter statistics.
So you should have the statistics in front of you. I don't think there's anything that really stands out. Just a couple of things to note. Our Nurse Family Partnership Program, which is part of the national program, their data system, they got a new data system that's been really struggling. So we haven't been able to get statistics for about 4 to 6 months accurately out of that system, and so that's why those numbers look a little bit different than what they should be. And then the jail, we have partial numbers, but we don't have census numbers. They tend to, when they get busy over there, then we don't always get that feedback from numbers. So those would be the two things. But if there's any other questions you see that stand out to you, please let us know.
I think we had talked about last time, Nurse Family Partnership numbers being down from last year. So despite system, I mean, overall, are they?
They're
down?
actually,
Or we think that they're up?
yeah, they're actually doing pretty well. I think, we had added a new staff person, and so there was, sometimes when you do that, there's that training lag time. And so I think we're actually getting closer to capacity, and we really have developed a good network of a referral base within the community between Essentia and Sanford and Family Health Care to get those first-time moms in. So I think it's actually doing pretty well.
Okay, perfect. It's good to hear. Other questions on the statistics?
Not so much a question, but these numbers in our harm reduction categories and homeless outreach and syringe services and withdrawal management are just absolutely astounding. Just astounding what we're doing in our community. The 30 Narcan saves, 1,077 or so engagements. I mean, this is just phenomenal what we're doing in our community. At some point, I wouldn't mind us maybe at Public Health having a focused discussion further about our programs here with the Mobile Outreach Unit. And I know Jan's not here today, but what they're doing is a national model. And if we can, so just don't gloss over these numbers. It's phenomenal. And I hope your staff all know how significant it is.
And specifically, the mobile outreach has done
Amazing.
wonderful things, and we will be getting funding through DHS to expand that program
Excellent.
going forward. And so we would be able to do those services, in a 16-hour shift rather than an 8-hour shift. So that, I think, that's made a huge impact on the ambulance, on the healthcare systems, just to,
Yeah.
kind of have that lesser level of support needed to help those folks. So
other questions or comments? Okay. All right, legislative update, speaking of DHS.
Yeah, so this is our, Chelsea had asked that this be a standing topic. So we, actually it was last week, we were supposed to go out, was it last week, 2 weeks ago, go out for Public Health Day, and that's when the weather went totally south on us. So we didn't make it out there, but we did, Justin had developed a really nice kind of a meet the team kind of handout with kind of talking about our health department and kind of priorities for us that we had sent to our legislative people, but just some things that we've kind of been working on. Probably the biggest win for us so far has been in that House Bill 1004, which is the state health department budget. Initially, there was a proposal to decrease state aid to local public health by $525,000, which would have been a really big hit across the state to us. You know, state aid is that funding that we can use for gap services, that if there's outbreaks, if there are different things that we have to respond to, emergency preparedness things, different things like that, it kind of helps in those areas where we don't get specific grant funding for. So that was actually reinstated. Now that it's gone through the House, it's back. I believe they took it out of the Tobacco Prevention and Control Fund for right now, but it is coming back to local public health, so that was a significant step for us. You know, there's been a whole lot of tobacco things. Many have failed. Tobacco tax, all those different things don't seem to really be going much of anywhere. The thing that seems to be on people's radar a little more is that e-cigarette and liquid nicotine and the youth. So I think there will be some movement with those throughout the session, but I think as far as our tobacco tax, and I don't foresee that necessarily going anywhere. We do have a handout for you guys that we can give you that just talks about the e-cigarettes and the youth use, and it's alarming. And so those are things we continue to watch. There's a few environmental stuff that's out there, and then our primary seatbelt passed one, but it barely passed. So we'll see if it works as well on the flip side, but those are the things we're kind of watching right now for us.
Okay.
But if you guys all have anything to add, jump in.
Can you send us the legislative priorities that you have? I'll be in Bismarck on Monday and Tuesday, and I work a lot with DHS on several items, and much more legislative activity than I anticipated. So
Yeah.
I might as well do some double duty.
Yep, and I actually could send you the document. So every Friday, local public health around the state has a legislative call where we talk about, you know, what are we watching, what's going on with certain bills. I could send you that document as well that has kind of everything on it, from, you know, environmental stuff to nursing stuff to DHS stuff, and that might give you some just a little insight into what we talk about on those meetings.
I'll be there Monday, Tuesday. So if you can get into me before Monday, it'd be great.
I think it would be helpful. I would like it as well.
I'll just send it to everyone.
Okay, perfect. Chad, you had some questions?
That's what
Okay.
I'm typically out there every week myself, so.
Perfect.
And I think Public Health Day at the legislature, at least for the students, was rescheduled, I was told, by Mylan. She mentioned something about March sometime, so I don't know if it was just the student piece, but I can ask for clarification on that, because I was planning to go, and then the weather. I'm glad I didn't go, because I don't think I would have gotten back.
Yeah, are you referring to when we didn't go for Public Health Day?
Yes.
Or? Yeah, and they actually did have it. I mean, there were some across the state but I'm sure there's other
Yeah.
days. But yeah, the weather hasn't been helpful for us getting there sometimes, so.
Perfect. Any other questions or thoughts? Okay. All right, the TB program overview is next.
Okay, so I had asked some of our expert staff to come and talk about TB. As you know, at a couple of the past commission meetings, this topic has come up, and so I really felt it was important that we do some education to all of our board members and the public just on facts and on our program, what we do with TB, so that we could just have everybody be more informed. So Dr. Lako is our health officer, and she's going to start the presentation, and then I don't know which order you're going in, but Ann Hirsch is here. She is our TB coordinator at our office, and then Dee Pritchett is here from the North Dakota Department of Health, along with Lindsay. So I don't know if Lindsay, if you're speaking, or if it's just Dee, but welcome to both of you, and thanks for doing this.
Right. So these are just little TB bacteria that you get to look at. Nothing gross or anything.
Dr. Lako, could you move the mic over, please?
Is that better? Okay. I'm kind of short, so I suppose I should have adjusted that. All right, so our objectives are today describe TB and how it's transmitted, as well as explain the difference between TB infection or latent TB and TB disease, which is active TB. And then Ann will go over what's happening in Cass County and what programs we have, and then Dee will go over the review process for immigrants and refugees. So what is tuberculosis? It's always kind of on our mind. What is it? Is it bacteria? Is it a virus? What is it? Okay, still not loud enough. So what is it and how is it transmitted and how scary is it? Honestly, in working in the healthcare field, I'm not scared of it at all. I would sit by on a bus next to a person that had TB. I'd be fine with it. All right, so it is a bacteria. It's caused by a couple of them, Mycobacterium tuberculosis, as well as Mycobacterium bovis. It can be in the lungs, which is the most common place. Otherwise, it can show up in the kidneys, spine, brain, lymph tissue, many other places, actually the oral cavity, and it can be almost anywhere in the body. But really the ones that are most infective is when it's in the lungs and they're active. And we'll go over what latent versus active means. So latent is just infection, and they have no symptoms. They cannot give you TB. They can walk around in the community and take their meds and not bother anyone. They won't feel sick. They won't look sick. They can't spread it. So even if they do have a cough, they're not going to spread it. Positive skin or blood test will happen, but they'll have a normal chest x-ray, they'll have a negative sputum smear and culture, and they may never develop active TB. Only about 5 to 10% of people that are normal and healthy will contract TB or actually have their TB go from latent to active. And then active, they have symptoms. They might have a cough, or they might have like a bulge on their neck that's a lymph node that's infected. And they may feel sick, and generally do feel sick, and they actually look ill. They don't look happy and ready to go to work. They will actually look like they might have a pneumonia or something like that. And they can spread it from person to person, but it doesn't spread all that easily, and I'll go over some of those, how that happens. So they will have a positive skin or blood test. There's very few that are false negatives. They will mostly likely show up. It is a pretty slow-going bacterium, so if they do a sputum smear, it may take a couple weeks for that to be positive. So it just depends, or if they do a culture, excuse me. And a lot of them may have extrapulmonary TB, and they may not be able to spread it at all, because if it's not in the lungs, they can't cough it up. If it's just on a lymph node or something and you touched it, you couldn't get TB from that. So what are the signs and symptoms of active TB if it's in the lungs? And in fact, some of these can be even if it's not in the lungs, but if it's in the lungs, they may have a bad cough that lasts 3 weeks or longer. It's not one that they get a cough for a week and it goes away. That's usually a cold. Excuse me. They may have pain in their chest when they breathe. It might be kind of a pleuritic type sensation. They'll maybe cough up blood or sputum. They'll have weakness and fatigue. They might have had weight loss over those 3 weeks because they're just not feeling well. Appetite, may have chills and fever, and most common they have night sweats. So whenever we ask people that's had a prolonged cough, longer than a couple weeks, we'll ask them, are you experiencing night sweats or chills during the day? And generally they will say yes. And that'll point us toward getting a TB test on them and maybe putting them in confinement or quarantine them in their home for a little while until we figure out if it's active or not. So how can you get TB? It is an airborne infection, so that's why the coughing and the sneezing is so prevalent in spreading TB. And it spreads from person to person. You can't really get it from an animal or anything like that. Cough, sneezes, speaking, and singing. It's got to be more of a forceful kind of, if someone's yelling at you. If they're just talking in normal manner, they're probably not going to spread it at all. If they're yelling at you or they, sneeze on you, then maybe. And it's usually repeated, prolonged exposure. So it's someone that lives with these people or works with them every day, or really is in confinement with them very often. So it doesn't happen, in one episode usually. It could, but it's very unlikely. And it's not spread by shaking hands or using the same toilet or any of that. You can even share a toothbrush, you can kiss them, and you won't get TB from that. So no mucous membrane contact. It usually is close contact of the person with infectious TB. So if you go and visit somebody, a relative that lives in a TB prevalent country, and your relative actually has TB and you stay there for a few weeks, repeated exposure, they're coughing on you, coughing in the home, sneezing in the home, and you walk into that cloud of TB, because TB can actually stay in the air for about a couple of hours. It usually falls to the ground pretty quickly, but it could. And then there's those that have immigrated here from other areas that have a high prevalence of TB, and they've been living in our community for a while, and they may have had latent TB, didn't know it, and became active for some reason, so that could happen. Children than less than 5, usually they don't have this great immune system as adults do. They haven't gone through all the colds and everything like that, so they are at high risk of getting it and spreading it. As well as homeless persons, IV drug users, and persons with HIV infection, just because they're more likely to get active TB than stay latent, and I have some statistics on that as well. And then persons that are in close contact. So some of our folks that maybe work in the Gladys Ray shelter or things like that, they might come in contact with those people on a daily basis. So nursing homes, it can be in the college age group if they're in dorms, things like that. So here's the fate of the droplets. You're hoping everyone covers their sneeze because that's probably the most prevalent, where the organisms are gonna be the most, 4,500 to 1 million little infected droplets. But if they're covering their sneeze and it's not going anywhere, you're not gonna get it. Coughing is 0 to 3,500, and then talking is just 0 to 200. And your body may take in one of those droplets or 2 of them, but our body's immune system, if you're healthy, is most likely gonna get rid of that. You're not gonna sit with latent TB. It's gonna destroy that bacteria. So you're not always at risk if you come in contact with someone. It's really the amount of droplets. So if say someone sneezes directly on you and you get 1,000 droplets in there, your body might not be able to take care of all those 1,000 droplets, but that took care of the 200 when someone was speaking with you. Cool. And as they're getting treated, their infectivity will decline, and that's when we take them off quarantine if they're feeling better and looking better, those types of things. And the people that are most risk for TB are those that have weakened immune systems. HIV infected, or maybe they've got AIDS already. Those with substance abuse because they're just not taking care of themselves, not eating correctly. Diabetes are sometimes have a lower immune system, especially if they're not taking care of their sugars and things like that. Renal failure, low body weight, just the real skinny, so they're not getting enough nutrients. And organ transplant is a big one. Organ transplant and cancer. I've seen TB become active in these folks quite often. So, and then anyone that's being treated with steroids or immune modulators like Humira. I can't think of the other ones. I think I have some on the slide, this next slide. Oh, no. I think I have a few others, but I can't remember the names. So a normal individual like you all that have great immune systems, you have about 5% chance of an infection or latent going to active TB in the first 1 to 2 years. And then after that, later in lifetime, you might get a little bit older, your immune system becomes a little more weakened, and then there's another 5%. So it's about a 10% chance that you're gonna go from latent to active. So 90% are gonna walk around with latent TB and never know they even had it, and never have active TB. So. Those with weakened immune systems, if you have HIV and TB together, it's about a 7 to 10% chance every year. Children less than 5, they have about that 10% chance as well. Diabetes has about 15% chance because if they're not taking care of their sugars, they're more likely to get run down and infected. And then there's the Humira, Enbrel, and Remicade. Those are the TNF-alpha inhibitors that we use for, rheumatoid arthritis, Crohn's disease. They can even use it for psoriatic arthritis. You see those on TV all the time. The golfer or whatever his name is. He would be at risk. So. And who should be tested? Someone who spent a considerable amount of time with someone with TB, just to see if they have latent TB, just so we can treat them early so they don't get active TB and spread it to other people. Someone who has a cough for 3 weeks, we may think of testing them. They live or work in a high risk setting, like a nurse that may have taken care of a patient that they didn't know had TB, thought that was just a pneumonia, those types of things. Correctional facilities, so our health officers and nurses that work in the correctional facilities, long-term care like nursing home, because as you get older, you're at more increased risk for that latent TB to become active, and then homeless shelters. Those with HIV, those that inject drugs, and someone that just looks sick with a weakened immune system, and then travel to a TB-ridden country. Do you want to take questions at the end, or if they're... Okay. Anne will be next.
Good afternoon. I'm Ann Hirsch, and I'm the TB coordinator at Fargo-Cass Public Health. And I wanted to share with you a little bit today about the services that we offer at Public Health and kind of what TB care looks like in Cass County. We do some testing services. We are currently offering a test called the QuantiFERON TB Gold Plus. That is a blood test that we draw in our lab at the health department in Fargo, and then it's sent to the North Dakota Public Health Lab. The cost for that testing is paid for by the client, unless they are a contact to an active case, in which case it is covered by the North Dakota Department of Health. People usually choose to be tested for TB because it's either a school or an employer required test before employment. We have a limited amount of TB skin test or tuberculin that we also can offer. That's the old original TB testing. We use that primarily for off-site testing or infants, because QuantiFERON, the blood tests, have not been extensively studied in very, very young children. So generally, we still use the skin test for those folks. So what if a test that someone comes in to public health, has a TB test, and it's positive? Then that person is referred to their primary care private medical provider for follow-up, which would include a chest x-ray, and depending on the results of that x-ray, perhaps some additional testing. If a diagnosis of latent TB infection is made and the client lives in Cass County, then they are referred back to us for treatment and case management. We provide them medication and follow them while they take their medication. So for latent TB infection, which is a person that has a positive TB test and negative chest x-ray, they're not sick, but they have the TB bacteria within their body. In the United States, we routinely treat those folks with medication as a preventive so that we are hoping to eliminate the possibility of them developing active TB at any point in their life. All Cass County residents diagnosed with latent TB infection can receive their medications and case management from Fargo-Cass Public Health. The way that looks usually is they go see their primary care provider who diagnoses this latent TB and decides to treat them, then sends us the referral. We work with the North Dakota Department of Health. There is currently a centralized pharmacy in North Dakota where the medications are sent from to us, and then we provide those to the client. Usually for adults, it's on a monthly basis, and they self-administer those meds. But we do follow them, we case manage them, we watch for side effects, and all things like that. If it's a child that's being treated, we actually give them their medicine, usually 5 times a week, because that's called directly observed preventive therapy. And the reason we do that is because children are more at risk, as Dr. Lako had said, of developing active disease quicker and getting sicker than healthy adult would be. So we want to really ensure that those children are completely treated and they actually are taking their medication. Typically, treatment lasts for 4 to 9 months. The North Dakota Department of Health keeps records on people with latent TB infection indefinitely, which is a big advantage. So if someone, say, moves to another state, 10 years later has another TB test, they aren't necessarily having to go through additional treatment, or there's not a concern if there's already an existing record of their treatment. Latent TB infection is never infectious, so treatment is voluntary. Because those folks pose no public health threat. They have this condition that can harm themselves, but they're not a threat to anyone else.
Excuse me if I could for a second.
Sure.
That's the point that becomes a focal point, is that they can become infected and active. And help me understand that when we say they never can, but then they can become active.
There's about, for a healthy person, there's about a 10% chance throughout their lifetime that they will develop active TB if they have TB infection. So 90% of people will live their entire life without ever getting sick. Their immune system handles that bacteria, keeps it contained, and so it never becomes active, reproduces, and makes them sick. But about 10% of people do develop disease because either their immune system fails maybe because they have another health condition, or just age, or it could be just any number of reasons.
And at that point, it can be infectious.
Yes, active TB can be infectious. It is not always infectious, but it can be. So we also treat active TB too. Active TB and actually LTBI now also are reportable diseases in North Dakota. So if there's a suspect or a diagnosed case of active TB, the health department is usually involved quite early on. And we work with both that provider, the individual patient, the bigger state health department, sometimes other state health departments. And we kind of all work together to look at what their health situation is, if they are infectious or if they're not, and then we actually provide the treatment for those folks that are Cass County residents. And this is a little different treatment than latent infection. They are often treated longer. They're treated with several drugs, and their treatment is always directly observed for every single person that has active TB throughout the entire course of their treatment. So the TB nurses or our staff actually either visit those folks in person every day and watch them take their pills. Recently, we've been using some electronic directly observed therapy, so we're doing some video administering of meds, which works out in many cases really well for everybody, but it doesn't work for everyone. If they are infectious, we work on being sure that they're isolated until they become uninfectious, which often isn't too long into their treatment, but it varies with each individual case. As I said, treatment's always with several drugs. Lasts 6 to 12 months on average. It sometimes can go a little longer than that. Treatment for active disease is not voluntary because there's more of a potential threat to the public, so we require them to be treated. We enter into a contract with them. We have several things that we require them to do. They need to adhere to the direction of their provider and their the health department. And there's some recourse for us if they choose not to do that. In conjunction with treating active TB cases, if a person is considered to be infectious, we also look at those folks who have spent time around them and might be infected by them or had some TB transmission. And we try to identify and contact those people, get them in to be tested as well. So there's different scenarios and time frames and things we look at. Each case is kind of individualized, but if those people are tested positive, then they're considered latent TB infection, just like the first group that would have come in voluntarily for a test. So they're treated as well, but those folks are not at risk of being infectious or being sick. We treat them preventatively, basically. Contact investigations sometimes can be just an immediate family. It might be just 4 or 5 people. It can be many hundred people. It can be a very big contact investigation. So oftentimes, if needed, we partner with our local state folks. We sometimes work with other states. If need be, we work with federal partners. We have there are 5 national TB centers situated around the United States, of which we belong to the center called Heartland in Texas, and they offer us a lot of consultation and actual hands-on kind of help should we need it. CDC has also been helpful to us in the past if we need actual bodies to help us with follow-up. I talk a little bit about electronic disease notifications, or EDN'S. This is CDC records that track refugees and immigrants coming into the U.S. with a variety of infectious or communicable diseases, of which tuberculosis is one of them. So they look at where these folks settle, and these notifications are sent to the state of North Dakota and then dispersed down into their county of residence. So we also try to locate and contact those people and facilitate them getting their medical evaluations done that they are needing further follow-up. So these are people that have had their screening done overseas. Something was a little abnormal that needs further addressing after they arrive in the US. So we try to assure that that is happening, and then we would also provide their treatment as well because they live here in Cass County. Interestingly, we were able to find, last year we were able to find 100% of the people that were living here that we were notified about and facilitate their follow-up. But interestingly, 1/3 of those people ended up testing negative for TB. They did not actually have any TB. So overseas records, depending on the country, are sometimes hit or miss a little bit. Are there any questions? It's just kind of a brief nutshell of how it looks at how we work every day, but does anyone have questions?
A question. When they've had active TB and you've treated them, do they return to a latency state then after that? If it's not a cure, is it? It would.
Well, it really.
Would they continue to carry the TB?
We consider it a cure. Yes, we can cure TB, but they will always test positive if they have a TB test. I kind of think of it like an allergy test. Your body's sensitized to the test antigen and will respond. So a test would stay positive, but we believe that they are cured. It is possible. It's not common at all. It's quite rare, I think, but it's possible to be reinfected once you've been treated. If you have ongoing risk or you're exposed again, some very few but unlucky people end up getting infected with TB more than once. It can happen, but we don't see that very often, in my experience anyway.
And if you're an average person in our community, would you be worried that you would pick up TB?
Not at all, no.
Right. Me neither.
Really very low.
I work in the emergency department. I'm exposed to more folks with TB than the average person in this community, and I have no fear of contracting TB.
I wouldn't be afraid at all. I've worked here almost 40 years, and I am TB negative. I don't have TB, and I work with people that are infectious. So
I think it's good to have some perspective. If you look at total deaths in the U.S. from TB, I looked at the last year they had data available, it was 2014, and there was a total of 493 deaths from TB in the entire United States. If you contrast that with influenza, there was, I think the last flu season, there was 80,000 deaths. So I think when we're talking about public health risks, I think it's good to have some perspective and allocate our resources appropriately and allocate our time and energy appropriately. So.
exactly right, yes. And really TB is not like the common cold or some other viruses and things like that. TB is really quite hard to catch. Okay. Thank you.
Hello, my name is Dee Pritchett. I am the TB controller for the North Dakota Department of Health, and I want to thank you for inviting me to be here today and just kind of explain a little bit what we do at the health department and just kind of show you some of the good work that's actually being done throughout the state. So I'm kind of a data group. I like to look at my numbers, and hopefully I can tell a story by showing you some of the statistics we have from the past year. So if you look at the map, you can see that most, let me start over. So every state in the US has had at least one case of TB in 2017, Those states that are highlighted in blue are the states that actually had above the average of 2.8, which is the lowest incident rate, which means that if you divide out how many people per 100,000 are in that state, just how many cases there were. And North Dakota by far was less than 2.8% in 2017. And of the states that we have, 4 of them, Texas, California, New York, and Florida, see the most of our per count of how many cases of TB there are. And of course, they are our biggest populated states, but they do carry the most of the disease burden. When you look at where the cases are, you can see that our numbers of cases in the US are dropping. We only had one little hiccup, I think it was like in 2015, where we had a slight spike. But the directive we've been given by the CDC is to identify those individuals that have latent TB and get them treated. Until we get our individuals that are latent TB infected treated, we're never going to be able to stop the spread of TB disease because they will break down and pass it on to other individuals. When you look at this graph, about 2/3 of the individuals are non-US born, and then about 1/3 of them are US born. In North Dakota, last year we had 13 cases. So if you think about overall, there was like 9,000 some hundred cases in the US. We only had 13 cases. So really, we don't have that much TB here in North Dakota. And that's the whole state, that's not just Fargo. We did have a slight spike in 2012, but that was the most that we've ever seen. So we kind of average between that 10 and 15 cases per year. This is kind of a map. I was able to go back to 2000 and just determine how many cases of active TB we had in each of the counties going back to 2000. And you can see Cass County did have 67 cases overall in 18 years. But if you start dividing that out, that's still less than 5 cases per year. So again, those numbers are really pretty low when you think about how much TB there is even in the US. Again, just kind of showing by the last 5 years, how many were US born versus non-US born. Usually, again, it's about 2/3 of our cases are non-US born, and then the rest are US born. What this story doesn't tell is sometimes some of these US born had travel over to a foreign country and were infected in another country. So sometimes it's really not fair to compare, are they US born or not US born? One of the things that we do whenever we get a person that has active TB and we have a positive culture result, we're able to send that specimen to the CDC and they're able to analyze it and do genetic testing for us. And when they do that, they do a genotyping and they're able to determine how much of that is based on a recent exposure or if it was due to somebody who's had the disease for a while. And what they were able to determine was that only 13% of the disease in the US is due to recent transmission. And so what that means is that person has had that bacteria in their body for a very long time. And again, kind of like Dr. Lako explained earlier, it's just they become immunocompromised, they become diabetic, HIV, whatever, and their body just isn't able to contain that bacteria. And they know their body just isn't able to contain it and they break down and get active disease. So it's not due to any recent transmission. So some of the risk factors for TB in the United States, again, it's just travel and individuals that are arriving from other countries. And you can kind of see the countries where most of the TB is in the world, and a lot of it is in the African countries. And again, just kind of reiterating some of the risk factors when somebody is identified with TB. One of the things that they're really finding lately is that almost 20% of those that have TB are now reporting that they're diabetic. So one of our pushes that I'm going to be working on is to be working with physicians that deal with diabetes and just encourage them to have their patients tested to see if they have latent TB so that we can prevent them from breaking down into having active disease at a later point. So again, the more we can identify somebody with latent TB, get them treated with 4 to 6 months of meds, we can prevent the active disease in the future. Completion of TB treatment. This is for active disease. Like Ann was mentioning, we use DOT, or directly observed therapy, and 100% of our patients receive their medication and they're all treated appropriately. And yes, we do bring them to cure. And so we're very fortunate to have very good nurses in our state that are able to help with this. I wanted to talk a little bit about the process of when a new arrival comes to North Dakota. First, I want to kind of explain that when individuals come to the United States that are refugees and immigrants, there is a formal process for them to be evaluated prior to coming to the US. What doesn't happen is there are many people that come to the US on non-immigrant visas that never have any TB testing done. So like say they're here on a work travel, just here people visiting, there's no requirement for them to have a TB test prior to coming to the US. And so sometimes those individuals may be at more risk than those that are coming through as new arrivals. Before a person that is identified as either an immigrant or a refugee comes to the US, there is a formal process that they have to go through. They are examined prior to coming to the US. They have a test done for TB, syphilis, gonorrhea, Hansen's disease. They're checked for parasitic infections. They have like a mental health evaluation. There's a number of things that are done prior to them coming to the United States. If they do have a positive TB test, they do get a chest x-ray done. And if any of those are abnormal, they have to have sputums collected. And then if everything's negative, they are cleared to come to the United States. If anything's abnormal, they have to receive their treatment prior to coming to the US. And then they also do things like vaccinations, getting them up to date and that kind of thing before they're allowed to travel. So what happens is there is, like Ann was mentioning, there's a program through the CDC. It's called the Electronic Disease Notification. And that's how I get notified at the state. I get an email whenever there is someone that it needs to be addressed and found. Or typically every day I just go in there and make sure that there aren't any new ones that need to be addressed. So anyway, it's very secure, and there's only a few people in the state that have access to this program. When they come to the United States, they are given a classification. They're either a B1, a B2, or a B3. If they have a Class A designation, that means they are not allowed to travel to the United States. Those that are Class B1 are those that we have our strongest that we want to get screened and tested, because in the past they may have had a positive test as well as an abnormal chest x-ray, and they did have workup done in their country which allowed them to travel, but we just want to make sure in the time that they left their home country prior to coming to North Dakota that they haven't broken down and developed active disease. And so those are our main emphasis for those that we want to get in and evaluated, as well as our B2s and B3s. I just kind of wanted to show you a little bit about the good work that our nurses are doing in North Dakota. So this shows the green line is the benchmark that the CDC gives us that they want us to meet. You can see in North Dakota we far exceed what the benchmarks are. So say in 2017, within the first 90 days of a new arrival coming to the United States, almost 77% had their evaluations done. And there's some that it just takes longer than 90 days to come in, but that's the benchmark the CDC uses for us. And then once they have their evaluation, this pie chart just kind of shows, so it shows that we completed like 79% of those. There was 3 individuals we were not able to find. 5 of them we started their evaluation, but we weren't able to find them to complete their evaluation. And then 3 of them are listed as unknown. For those new arrivals that we did do evaluation, this is kind of what Ann was mentioning. We had a number of them that basically were determined not to have TB. And one of the reasons for that is many countries don't have the technology what we do. So kind of when Dr. Lako was explaining, they did a skin test where they do the test in the arm. But in many countries, they're vaccinated with what's called BCG, which can cause a false positive skin test. So then when they come here to the United States, we do the blood test, which isn't impacted by that BCG. So they really never were a positive TB test. So we're able to determine that once they arrive in the US. So that takes, about, a good fourth of them that probably never needed to even be tested. Over half of them are identified as having latent TB, and then our recommendation is that they get treated. And then there's some of them that they were exposed to TB, but again, there's no infection there. So if you add up the no exposure and the non-infected, it looks like a good third, even a little more than a third, really didn't even have TB. As far as treatment, we're very good about getting our individuals in for treatment, and 100% of those that were identified as having latent TB were treated, which means that we've done everything that we can to spread the disease of TB because we've treated them with their latent TB. And again, this again shows just how many arrived to how many actually completed treatment. And again, all 16 of ours that were identified completed treatment. And this is for the whole state, it's not just for Fargo. With that, I want to thank you. This is Sandhaven. If you've never been to Sandhaven, I recommend that you go there on Halloween. Apparently the ghosts come out then. So, and with that, I will take any questions you might have.
Questions?
If I might, just to really cut to the quick. It's been suggested here that refugees are the problem and that we need to stop allowing refugees to come here. And I know this information gets difficult to get our arms around as laymen, but is there any validity to that at all, that notion that the refugees are the problem and that we need to stop allowing refugees in?
So hopefully you were able to tell by some of just even the charts and graphs that I had is, the individuals are screened prior to coming to the US. So we know they're disease-free when they're leaving their country. And then once they're reevaluated when they're here, they're still disease-free. They may have latent infection, but so can anybody else that's walking in the streets. Until you're tested, you don't know you have latent TB. And even those individuals that were identified as having latent TB, we treated them with antibiotics so they don't go on to develop active disease. So in my opinion, no, I don't believe there's the concern for them developing active disease and spreading it to the community is there.
Thank you.
Mm-hmm.
So this isn't probably the right person to ask, but when you're classified as a B1, the percentages of people that are completing their medical exam within 90 days, how is that not closer to 100%?
So individuals come through as either a refugee or an immigrant. Those that arrive in the U.S. as refugees are provided funding. For those that come through with an immigrant status, there isn't any funding given to them to have the testing. Sometimes what happens is that they relocate and we just aren't able to find them. That's probably our biggest challenge, is that they're given a North Dakota address that they've arrived here, but when we go into those communities, we can't find them. So did they really arrive in North Dakota or not? I don't know. And so that's a big reason why a lot of ours aren't evaluated, is because we can't find them.
So in theory, they just disappear, or are they hopefully keeping their word to the American people? They're being tested wherever they wind up.
That I can't answer.
Thank you.
Mm-hmm.
Any other questions or comments?
Thank you for all that information. That was wonderful.
Yes, thank you very much. Okay. Well, that was the last topic, and I know we're a little bit over time, so I think we're okay to adjourn, and we'll see you next April 12th. And in the meantime, we're going to get some legislative updates weekly, and so look forward to those. Thanks, everyone.